the expected increase in the burden of cancer. This is the best buys. Best buys, that is being promoted by WHO, where you can intervene with modifiable risk factors. So we know that there are risk factors such as tobacco, smoking, alcohol, the obesity, and so on that contribute to development of non-communicable disease in general, but in our situation, cancer specifically. Yeah, but by far, there is the increase in life expectancy that is contributing to the predicted increase. But we also have to pay attention to the other modifiable risk factors. Next. So let's turn our attention to the right side. Prevalence of smoking. Whereas in the developed world, there is a decrease, over time, less and less people are smoking. China, USA, the UK, and so on. In Ghana, the story is different. Congo, story is different. It's increasing. It's rather increasing. More people are taking up smoking. So it's something that we have to pay attention to. Next. So, burden of cancer low relative to countries with high HDI, but projected to increase. Does it mean that we should just sit aloof? The blue represents incidence and mortality. So we'll use breast. Breast is a common cancer. If you look at the incidence and mortality for breast for high human development index, you see that mortality is about a fifth of the incidence, right, for high HDI. But for low HDI, it's about half. It means that there are actions that have been instituted by these countries to reduce the effect of cancer, which we can emulate, and also try to have local activities which we can pursue to reduce the effect of cancer. Next. So definitely you can do something about it. Again, on this slide, you can see that over time, burden of the mortality from cancers, we are using breast, it's reducing. Denmark, Israel, Canada, it's reducing over time. Compared to less developed countries, Mauritius is on the increase, Colombia, South Korea, and so on. So what are they doing to reduce the burden that the rest of the low HDI countries are not doing, and which should be adopted to reduce the burden of cancer? Next. In my opinion, this represents, I'm sure the list is not exhaustive, but the time allotted cannot take care of all the challenges, the pain points of cancer. But this is what I selected to consider, and probably would deal with about 90% of the problem. Late presentation, distribution of treatment sites and investigative tools, drug availability, cost of treatment, referral patterns, complementary alternative medicine use, and issues with diagnosis, distribution, and number of specialists. Next. Right, so late presentation. For stage 1 and 2 disease, please go to the previous slide. For stage 1 and 2 disease, Côte d'Ivoire, this is from the IAC, the proportion is 26%, and for stage 3 disease, about 45%. Looking at Europe, UK, the proportion of stage 3 disease is very low. So it's the opposite. Please, previous slide. So the proportion of stage 3 disease is quite high in Ghana, Côte d'Ivoire, and countries with low HDI, compared to the Western world, where you rather have the reverse, high proportion of stage 1 and 2 disease, very low stage 3 disease. Please, previous slide. Or next slide, please. Next. Right. Okay. So for, Kolebu's institutional data, but it's not too different from Cote d'Ivoire and Egypt, where stage 1 and 2 forms a very low proportion compared to the developed world. Next, so it is real that we have late stage presentation, and prognosis is linked to stage at presentation. So for early stage 1 and 2, the Kaplan-Meier plots will show you the outcome is almost 100%, whereas for stage 4, the story is different, very high mortality. Next. Figures from Kolebu Teaching Hospital, it is not projecting well, but if you look at the variables and under stage, for stage 1 disease, our survival rate is of the order of 90%, which is not different from what happens in the developed world. But for stage 2 and 3, for stage 3, 5-year survival is 33%. So we want to improve outcomes. Patients should present early. Next. So what are the mitigating factors? It's a conundrum which can be difficult to entangle, but we have to start from somewhere, disentangle, but we have to start from somewhere. The access delay, diagnosis delay, treatment delay, patient's interpretation of symptoms, the paradigm to disease causation. If it's, of course, witchcraft, then you should pursue other means other than going to the hospital. You see, so there are barriers, apart from financial barriers, there are logistical barriers, psychosocial. Resort to use of complementary and alternative medicine is part of the psychosocial problem. So let's say a patient has bleeding PR. What is the interpretation of the patient himself? And for which reason he would require, he will go to hospital. And then so that will be first symptom, and then the time it will take to visit the first doctor. What about when they see the first doctor? Will the doctor ask for the age and know that when the patient is about 50, 55, and so on, he should consider cancer, or to be regarded as hemorrhoids, and to be treated as hemorrhoids for over a year before it will be sent to a place where the diagnosis can be made. So the access delays, right, but doctors, medical practitioners also contribute to the delays we have. And then after the diagnosis has been made, there are delays in treatment as well. Right? At the cancer centers, the distribution, are they such that the patients will have access, geographical access? So in an attempt to solve this problem, we always refer to the cancer control continuum, next, which we are familiar with. I'll just touch on bits and pieces of each of the items under the cancer control continuum, since we'll not be able to consider all of them. But this slide shows that screening, I'm using cervical cancer screening, as at the time of the study, the coverage was only 2.8%. And this is something that is preventable, right? From VIEs, you can diagnose them early, pap smear, which we've known for a long time. But our coverage is 2.8%. So the burden is not surprising that the burden of cancer of the cervix has not changed over 20 years. I'm not against celebration of Cancer Week and so on, but unless we make it systemic, and you see, after October, everybody will go to sleep. Nobody will talking about breast cancer. It's something that I've been saying over a long time. It should be systemic. It should be, there should be programs by the district health management teams. And you see, a program where they visit the communities, and there should be all year round messages and interventions rather than, I'm not saying that it's not important. That should just represent the peak of our intervention. But throughout the year, there should be action. Yeah, so HPV positivity, 59.2 among cervical cancer patients. And in our cancer control plan. That is immunization and all. So it means if you were to immunize against HPV, you'll be preventing about 60% of cancers. This was a study sponsored by ROCHE. Next. So we just want to bring your attention to, it's not projecting the, yeah, I think it's here. It's a proportion of out-of-pocket payments. So a study between Kenya, Ghana, Nigeria. So out-of-pocket, you see that the reds are towards the ordinate, right? Well, the reds, and that is Kenya. Out-of-pocket payment is very high for Nigeria and Ghana, representing the yellow and the green. So most patients, in spite of health insurance, most patients in Ghana and Nigeria are paying for the services they enjoy. I mean, this is facts. We are not making it up, right? Next. So, and there's a relationship between expenditure on health and out-of-pocket payments. So you see clustering for countries from Africa. There's clustering of the data towards the axis, where low government health expenditure and out-of-pocket payments, you see the clustering to this side, compared to the large circles where the government expenditure on health increases, then out-of-pocket payment to decreases. I mean, we are doing quite well, but there's room for improvement. Next. I want to also use this to illustrate the points we are making. We try to find out expression of HER2 amongst cancer patients in Ghana, and it's about 20%, which means 20% of the patients will benefit from Herceptin. Right. Now, next slide. What does Herceptin do? The previous one, please. Study AC followed by docetaxel, paclitaxel, compared to inclusion of Herceptin. You can see the difference. I mean, this is data that we all know, but it illustrates the use of Herceptin and what it can do, improving the survival. Of course, hazard ratio, which means 55% reduction in death relative to the the control group, and it's very significant. This data, also from the same study, out-of-pocket payments for patients who enjoy payments by a third party. Let's say you work in a multilateral or a big company, and therefore you will pay your Herceptin. For this group, the average number of cycles of Herceptin received was about 16. And for the out-of-pocket patients, it's about 7, which means if the drug is paid for, the number of cycles that the patients will take increases, right? So out-of-pocket payments is really a problem. And knowing that there's benefit from the use of the drug, it means those who cannot afford it are deprived of that benefit. Next. Yeah, so we're very lucky that in 2019, from the contribution of ROCHE with Ministry of Health, we had a technical committee that was set up to look into providing Herceptin next. So I'm happy to say that now almost every patient receives Herceptin as long as they test positive. So that is not a problem. I'm sure if this study is going to be repeated, we'll have upwards of 90% of patients receiving. So we expect that our outcomes, our survival will improve. Now, so previous slide. So previous slide. Yes. So specifically, countries in the Africa region appear to pay more for a package of essential cancer medication than countries in the Latin America region. And cancer medications tended to be more expensive than anti-infective medications and cardiovascular medications. So it looks like we are paying more. You know, sub-Saharan countries, we are paying more. Next. factors that lead to the late presentation. So, late presentation, next. Next, this is a multi-center study, multi-study background. The causes of late presentation, one of the reasons ascribed to was herbal and traditional medicine use, and this is referenced. Next. We know what complementary or alternative medicine is. Yeah, next. Yeah, so over time, the use of complementary or alternative medicine is increasing all over the world. This is just the expenditure on it. So with African countries, you see at the top blue, it's increasing. What can we do about this? Next. It affects outcome, and it affects the use of what we think that can cure patients. Next. So why do patients resort to these? Number of reasons. What we want to concentrate on is characteristics of the illness, the type of illness. Cancer, the outcomes may not be too good, and the length of the disease, the chronicity, and the gravity. Because of that, for cancer in particular, people resort to complementary or alternative medicine. Next. And the sources of information, I'm sure if you are a resident here, in Ghana, all the FM stations propagate that message. Some of the things they say, if I say it now, people will laugh. But you see, it's something that is advertised much more than the health education that we do. And there are a number of reasons why people use it among cancer patients. Next. But the doctor's approach, for us, conventional medicine is good, alternative medicine is bad. No overlap. Next. The new paradigm should be integrative medicine, where we try to integrate it. But the integration is based on knowledge. It's based on facts. Next. So WHO has some prescriptions as to what should be done next. If it is adopted, you see, there should be a policy. We have issues with policy. We should integrate traditional medicine within national healthcare systems where feasible by developing and implementing national traditional medicine policy. But what I want us to pay attention is safety, efficacy, and quality. You see, because most of the drugs that are advertised, there's no scientific data, no labels on them. So we should take over that space and control it rather than leaving it. As it is, we have left it. Everybody does what they like. Next. 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 So we have to control that space. Okay. So we've spoken about the factors that mitigate against a good outcome. We've spoken about late presentation, complementary, and diagnosis. We are doing well. It's much better than previously. The turnaround times have improved from when I returned from training. It could even be 6 months, 3 to 6 months, yes. If you say it, people are surprised, but that was a reality. But now it's about 2 weeks, and we do a number of tests. But the space is changing. I just put this in. See, so now we are moving into targeted therapies. So how well are we doing? You see, we are still at the H&E stage. How well are we doing? This is from a patient. So we had to do the PDL1, and it tested positive. Unfortunately, we don't have the drug. Well, we can bring it on a named patient basis, but it's very expensive. Not all patients can afford it. So we should move from the H&E and be able to do more molecular testing. Next. A state of radiotherapy resources in Africa. Next, just using it to illustrate points. Next. So if you look at the distribution, you see that Africa is very red. So most of African countries don't have optimum number of machines. Next. This is for Ghana. So if you live upwards of Kumasi, so Now we have 16 regions, but above Kumasi, there are no centers, right? So this affects the use of radiotherapy and therefore affects outcomes. Next. So that same study, the distances patients have to go through, in fact, Kolebu is 43 kilometers to arrive there averagely by patients. But even this, I think that it has deficiencies because some patients come from the north and will come and live in Accra. So the reported distance will be Accra, residing in Accra, but not in Tumu. So it's a problem. Next. So another study, next. The utilization of radiotherapy, if you look at the Ghana arm, the optimum utilization of radiotherapy by cancer patients, according to this study, for Ghana, if you look at the number 10, under 10, the column 10, it should be 51%. So 51% of cancer patients in Ghana should be treated with radiotherapy. But the actual utilization was 9, right? So 51% to 9. I think we should do better. Next. What about pathology? Just illustrating what we do. Kafui should not be angry with me. Yes, so this is recommendations by the American pathology guidelines for prostate reporting. You see the number of things that you should report, including the number of calls positive per the total number of calls taken. Next. This is ours. Nothing on number of calls. There are all kinds of things that, they've reported gleasons and so on. But you see, to refine our decision making, we should stick to the guidelines. So there's room for improvement as far as diagnosis is concerned. I know that some centers have started reporting. So started as other reporting. So the picture is not as bleak as I'm saying, but suffice it to say that still there are deficiencies. This bone scan, there's only one bone scan, functioning one in the country in Accra. So the distance problem applies, right? Next. There's no PET. Next. You see, this is patient with cancer of the cervix stage 1B. Without the PET, you treat the pelvis and the disease very well. But patients will fail in the pyotic region because even though it's 1B, the PET revealed that it's got nodes in the pyotic region. If you did it prior to your treatment, you would have upstaged and would have known what to do. Next. I use ENT services to just illustrate the availability of specialists. Next. So, if you look at Ghana, ENT surgeons per 100,000 of population is very low, 0.104, compared to 2.36, for instance, in the UK. So human resource also continues to be a problem. We are training. Ghana College is training, but it continues to be a problem. Next, yeah. So we should move. We are histological type, histological grade, molecular classification. We are the microarray-based gene expression, right? So some breast cancers, even though estrogen receptor positive, may have worse prognosis because there are other factors to be considered. We haven't gone too much into that. So there's room for improvement as far as pathology is concerned. Next. Lung cancer, new paradigm. Conventionally, you do surgery, platinum-based chemotherapy, post-operative radiotherapy if indicated, and then follow-up. But now, with the molecular expression, if you know what it is, you can use the PD-L1, anti-PD-L1 agents with radiotherapy for, let's say, stage 3B, and then the results are much, much better. So we should move from just reporting H&E to more molecular testing. That is at the cutting edge of technology now. We are deficient there. We have the national strategy, which needs to be upgraded next. We have the guidelines next. The problem with the guidelines is that it's sitting on our tables, so it hasn't gone into the district. Most people don't even know about it. But it's a very good document. If you look into it, it describes what should be done, even at the CHIPS compound. Because, I mean, everybody can palpate a lamp. The expertise you need, you're required to palpate a lamp, it's not too much. So they all have rules. We need to use the document. Next. And then to end the discussion, we'll talk about quality. Next. I'm just using this as an example where centers are certified. There's good criteria for that. You cannot just do what you like. You cannot say because you are a surgeon, you are doing breast surgery. You need to be certified. That is, so we don't want to be seeing patients who come to us, even though they have CA of the cervix, they've undergone subtotal hysterectomy for CA of the cervix, right? You don't want to see things like that. If you certify centers, you certify the practitioners, so it's not like you are doing what you like. So this shows a cycle of the various departments involved in the certification. Next. Just want to draw, just using this as an example. The analysis proportion of patients who received combined chemoradiotherapy before surgery. This is being assessed. So the surgeon cannot say that I'm just doing AP research. I will not do chemoradiotherapy. I'm using my own discretion. The registry, this is from the registry. This is one of the uses of the registry. Using registry cancer data, the inspectors have gone around and found out that, look, your institution, you are not using concurrent chemoradiotherapy. Right? So there's some form of surveillance. So it allows practitioners to do what is right. Next. So, I mean, the same point. Next. Yeah, this has been talked about already. Eventual aim is good health and well-being under the SDGs, specifically 3.4. Next. Yeah, so what is 3.4? Reduce premature mortality, that is death before 70 years from NCDs, which includes cancer, and promote mental health. Next. So the vehicle to achieve that is the UHC. And next, eventual aim is to adopt UHC, where access will be improved, which we've discussed, using radiotherapy. We've talked about financial issues, out-of-pocket payments, and then also quality. So when we pay attention to the bottlenecks, the conundrum that prevents us from obtaining good outcomes, I'm sure our patients will have the best outcomes. Thank you very much.
Ladies and gentlemen, let's do it better for him. A round of applause. He has served us with a full bouquet. We could probably have a buffet, and he has brought in patient issues, challenges with identifying, making diagnosis, the gaps in treatments, pointing us towards the right way, etc., national standards and policy. So Dr. Joel Yanni has set the pace for us to engage in further scientific discourse. I want us to zoom in on three things. We're coming to this conference and leaving with three things. When the organizers developed their manual, etc., they had objectives written in nice, beautiful English. But as you sit here, every time I want you to reason around these three words, because they are the focus, they are our expectation that you leave here with these. Number one, that you would learn. Can we say that together? Number one, we would learn. Number two, we would link. And so when we have breaks, make sure you engage others, you connect with them, build networks, see what resources are available, you are linking. So number two, we would link. And then number three, When we go back from here, we are going to lead. The resources we have gathered, the education we've had, the exposure to new practices that is working and what we have to change, we'll go back to fine-tune our practice and improve our care for patients. So 3 L's. We would learn. Number 2, we would link. And number 3, we would... All right. When it's time for break, we'll add a 4th L, and I'll let you know what that is. We're going on to our next session in the scientific session. We have another key moderator going to moderate a colloquium for us. And you know that since introductions are important, I have to get to the page to